recurrent to heparinsis. You can see the primary outcomes is recurrent VTE and major bleed. When the dust settled, not so much difference in terms of recurrent VTE or major bleeds between those two agents. So either can do. Yeah, so then the SELECT-D trial, again, patients with active cancer who have symptomatic PE, incidental PE or symptomatic lower limb, proximal DVT. Then rivaroxaban versus Alpestafin. You can see primary endpoint again, VT recurrent over 6 months, and of course major bleeding. And you can see again 54% of patients completed 6 months of trial. And, quite balanced. Major bleed was similar in the rivaroxaban and Alpestafin. So again, patient perspective, patients persistence with anticoagulation, low versus oral, somebody who just wanted to know, because people think that patients will be more compliant on an oral vis-a-vis an injectable. So you can see low molecular weight heparin, rivaroxaban, and warfarin. You can see where the adherence was. The DOACs and the oral ones tended to do better than patients preferred the oral service. Thrombolysis for sometimes we consider this for massive or submassive with ventricular dysfunction, massive idiofemoral thrombosis with risk of limb gangrene. So there are other ways of managing this, also submassive. Consider cancer status and performance status. You don't want to do this procedure when patients with less than 6 months life. Produce urokinase, tissue type, plasminogen and active. So other than the anticoagulants, thrombolysis also have a role in select patients. So in summary, cancer-associated VTE, the major cause of morbidity and mortality, prophylaxis appropriate for selected cases, especially surgical patients. Low molecular weight heparin is the standard of care. NOACs or DOACs role is being defined. Newer therapies needs further treatment. So I think in terms of guidelines, this is what we talked about. I don't think there's much difference. As for example, recommends they say low molecular weight heparin, hospitalized patients should be put on anticoagulants. Yeah. So thank you. So we go to the case. It is just one case I wanted to share. Patient we co-managed with some colleagues. This was a teacher, 49 years of age. We started treating him in 2020. He's known to have diabetes, he has CKD, he has hypertension. So significant comorbidities. Then he gets duodenal adenocarcinoma, which has the same risk in terms of cancer-associated thrombosis with stomach cancer. Yeah, so he comes in with projectile vomiting. That was sometime in 2020. Projectile vomiting, melena stool, weight loss, and of course, because of that, he develops acute kidney injury. By the time he's referred to us, his kidneys were really bad. It was a major challenge even working out his subsequent treatments. So we do a quick staging. Early staging becomes a challenge because of the kidney functions. Doing CT scans with contrast becomes a big challenge. But eventually we do MRIs, we find he has locally advanced disease. Since he was vomiting and he had an obstructive lesion, he goes in first and does a triple bypass. Yeah, so name was JK. So pulmonary embolism, bilateral DVT, duodenal adenocarcinoma, type 2 diabetes, CKD in one person. So already you are seeing this is a patient with, risks. You have the comorbidities, you have the cancer, is an active treatment, and we are giving even some of those drugs, like anti-angiogenic drugs that predispose him to developing malignancy, and he had membranous strokes, so that means he was bleeding. So how do you do primary prophylaxis for DVT for such a patient? So May 2020, after umbilical pain, abdominal pain, copious projectile vomiting, then he had these symptoms persisted. He has an OGD that shows a cauliflower-shaped tumor in the second part of the duodenum that was bleeding. Then we optimize him, do a CT, get an obstructed duodenal mass with features of gastric outlet obstruction. So histology shows adenocarcinoma. So he goes in and he has triple bypass surgery. Then he started on chemotherapy to get the first line. It's a regimen we call FOLFOX, 5-fluorouracil, oxaliplatin, glucocorticoid, every 2 weeks for 12 weeks. At one point, we tried doing prophylaxis, rivaroxaban, that's 10 milligrams, but the bleeding would not allow us, we stopped. So afterwards, he does some 6 months post-treatment, but his tumor progresses. Because of course, there's a lot of interruptions because of kidney issues, because of blood sugar fluctuation. So he fails the first 2 years later, and we start him on second line. And the second drug there is bevacizumab, which is an anti-angiogenic drug that also has a risk for DVT. So in April this year, so he's been on follow-up after finishing his second line chemotherapy in October 2022. In April, he presents to Karen with chest discomfort and heaviness. They find an ill-looking patient, pale with tachycardia, resting tachycardia. His blood pressures are low. Then on examination, they find that loud has probably some loud P2 because of pulmonary hypertension. They had a midline scar. Their other systems are unremarkable. So they admit him. They do a D-dive. For me, from here, I'll go straight to CTP, not waste their time and money in a D-dive. Because even if the D-dimer was negative, which is rare in patients in malignancy, you still go ahead and see. Then they do a 9 and okay, fine, maybe baseline, they already suspecting. So that was his imaging. You can see where the clot is, those filling defects. The features are consistent with acute pulmonary embolism. With the near occlusive thrombus with the left main, extension to the left upper. So is admitted. This patient now gives history of bilateral leg swellings, which was interpreted to mean that his kidney was failing. So he had that, and everybody said leg edema in a patient known as kidney. So it ends there. No need to because the kidney failure was suppressed. So when the compression ultrasonography is done, now he has bilateral thrombus, right and left. The right was the acute, and the left was the right was the chronic. Then the left was acute. Because they do echo rightfully. Some pulmonary hypertension, moderate TR, the ECG is normal sign of the room. So it's admitted to HDU, oxygen. They starting on noxaparin, about 60 kg twice daily. They starting on warfarin the same day at 5 milligrams daily, and of course other supportive care. Then afterwards, he's discharged home on warfarin 5 milligrams. Then we see him in the so here again, I think it's just the myth, management delay, the myth, lower limb DVT, maybe overlapping symptoms about the lack of risk stratifying him and starting with prophylaxis. But of course, also the challenges with doing prophylaxis in patients who are really at risk of DVT but are also bleeding. So then this last month he comes, and he has been on warfarin. Then look at the INR, 19.3. Then the Helena school gets worse. So some of the reasons why these dogs are now becoming quite popular. An INR of 1.3 is scary. And actually, he gave me a call. He said, "Oh, this is the INR. What do I do?" So I told him, "Come to clinic." He stopped the warfarin. We started him on vitamin K. 5 days later, INR back to 1.6. Would you restart warfarin? That's the question. Yeah, I think their guidelines, warfarin, those days when warfarin was the only drug, maybe you start at 1 milligram, and then now you have to monitor alternate day INR, so it becomes a little bit cumbersome. You have to start them on warfarin. He has PD, he has bilateral DVT. You cannot put an IVC filter because already he has had PD. So you just have to start, and you have to anticoagulate it. If you don't anticoagulate it, I mean, he gets another clot. And of course, the lower limb DVTs are both proximal. So we start him on the rivaroxaban 20 milligrams daily and monitor. Yeah. So at the moment, he's doing well. He's on the rivaroxaban 20 milligrams daily. His tumor is still not controlled, so he's probably going to need an anticoagulant therapy for long time. So thank you very much. No, it has taken too long. Open to questions. So,
thanks for the presentation. I think this one and antimicrobial resistance are like horror stories. I think we have questions. Last week we had antimicrobial resistance. Many people were scared of even walking back to work. Yeah, thanks, Dr. It's not more of questions, it's more of comments. We were talking about devices and their role in causing DVT or PE per se. I think we can learn from the renal team how they take care of their devices, and we have bundles of care created for these. PIC lines are finding their way back, and also the quarterbacks per se that you're inserting. Therefore, we should actually have an understanding of how to actually take care of these things, how much heparin or anticoagulation of whatever nature that we're going to use on these patients, and also as well as what has been mentioned, their role in sepsis in bringing these patients to us. Secondly, DVT, PE, and everything else, and you have shown in 1 or 2 slides of yours, have a bigger role for us in anesthesia in a different way. The occurrence of chronic pulmonary thromboembolism and right heart failure, which is a very difficult thing for us as far as anesthesia is concerned. So when you have that profile of what you're showing us, low levels of pulmonary hypertension for us, that's a pretty high level. Way beyond 50 is not something we are very comfortable with. But when these patients come to us again, whatever purpose that you want to give them anesthesia, that is another risk profile that you're presenting to us. Thank you.
Yeah, I think comments. I think the renal team, they have had this experience with catheters for a long time. For example, in oncology, you have these portacats, and it is just penetrating oncology care in Kenya. In other parts of the world, it is. And everywhere they have protocol on how to manage the chemo, because to put a chemo pot is about 110,000. And to, misuse it, and then you have to remove it. And most of the times at KNH, we've had such incidences where patient goes home without chemo pot getting locked with heparin. So they come back with upper limb DVT and chemo pot that you cannot use. So you have to remove the chemo pot, who inserts it, and what caused So I think it is really important, Doc, that we borrow from renal, that we come up with a way to manage. Even CDCs, I see, you start with one lumen blocked like that until then they get upper limb DVT. So that's well taken. I know RCVP of 50s. I know Dr. Nyaga is there. The way she was looking at me when I looked, I said some pulmonary hypertension. It is significant. Yeah. We see, and you see, that's the thing with PE. Sometimes it is missed and it becomes chronic. And not only with anesthesia, even further treatments, really, really limited. Patients get very chronic fatigue that they cannot explain. Really, or even in terms of quality of life. That is something we can actually prevent by risk stratifying, early diagnosis, and proper treatment of VT.
Any other question for Dr. So maybe I think you can take 2 questions online. Good presentation. How would you manage PT, DVT in patient with bleeding cervical cancer? And allow me to just merge it to the same. The next question, management of a patient who has DVT, is on dialysis and also on heparin.
Yeah, 2 good questions. The one on dialysis on heparin also has a malignancy, or just generally. Okay, fine. So bleeding, and anticoagulation has a bleeding risk that we have to always, and there are ways of improve cause and all that, heart bled, and many ways of predicting the risk of bleeding. Anytime you're starting any patient on anticoagulant, don't just look at the clot, look at the bleeding. If they're already bleeding, then you have to do something. Ask yourself, 1, must I treat this DVT? And that takes us back to the risk. So what is the malignancy? Is it a malignancy with a very high risk of progression of the thrombus? And what is the DVT? Is it proximal, distal, upper limb? What's the site of the DVT? And what is the risk of progression of the DVT? Then you say, this we need to treat. Then the second thing is, if the patient has not developed PE, for such patient with CS cervix and DVT bleeding, the best is to do an IVC filter. Now, IVC filters have also the risk of further DVT. The main reason we use them is for PE, to prevent PE before patients develop PE. So then, once you do that, then that will be the best. If not, then reassess, because if it is the tumor bleeding, treat, because for bleeding CS cervix, other means of stopping the bleeding include radiation. So you can do radiotherapy and anticoagulate at the same time. So you are treating, because this is primarily bleeding from the cancer, from the CS cervix, and the platelets are normal. If the platelets are low and less than 50 and they are bleeding and they have CS cervix, there's a room for you dose adjust your low molecular weight heparin, give platelets, anticoagulate as you treat the underlying malignancy. This the common approach is for people to wait for the bleeding to stop before it won't stop until you treat. So for that patient, I will treat the CS cervix, and radiation has hemostatic properties. I will also use other ways of controlling bleeding. For patients with normal platelet count, you can use drugs like samic acid and all that to control the bleeding. And then, if it is proximal DVT in a patient also with a higher risk of thrombus progression, then I will go ahead and do some adjusted anticoagulation. The other question about patient who is having the dialysis, and intradialysis they do heparin, but the nephrologist will also tell you they can do heparin free hemodialysis also if the patients are bleeding. So you consult the nephrology, they'll tell you whether the heparin is really needed or they can do heparin free. Some patients have already auto anticoagulated and may not need not all patients need heparin while undergoing dialysis. If they have DVT, most of these drugs can be used even in patients who are having DVT. So patients should not be denied anticoagulation because of because they are undergoing hemodialysis. Okay.
Any other burning questions?
Thanks, Dr. for the wonderful talk. My question, and I was hoping that you touch on it a bit about the heparin-induced thrombocytopenia. How frequently do you see it in your practice? And also, I mean, it's open to anyone who's really using heparin for prophylaxis. Thank you.
Yeah, that's another challenge with also with unfractionated heparin. So the incidence of heparin-induced thrombocytopenia has gone low because of the low molecular weight heparins. Yeah, but yes, it can be a challenge because patients can bleed and clot at the same time. They have and then have thrombocytopenia. Yeah, so usually when they develop heat, you need to tell from platelet. Patients have clots and bleeding, and then the platelets are low within 5 days of starting unfractionated heparin commonly. If they develop heat while on unfractionated heparin, then even using low molecular weight heparin may not completely lead to resolution of the heat. So there are other drugs that people can use, the direct thrombin inhibitors. But the problem is their availability, invalid. I've never seen it or used it, but out there, that is the alternative anticoagulation that one will use. But really, we miss the heat a lot because we do not look for it. And since these are patients who already have a clot, even when the clot is progressing and the platelets are dropping, very few people, detect heat. Because the other tests of detecting heat, those looking for those heparin cofactor antibodies, tests are also not available. So we use the clinical criteria. And sometimes heat can develop even through the heparin used to flush the peak lines, the central venous access, and all that. So the history of any heparin exposure, even in patients who have not developed DVT, is important because the clinical suspicion is the best for us here to detect heat.
So in addition, I think, especially in the ICUs, we use a lot of heparin flushing, and we've seen a bit of it, not much of heat, and especially because of the low molecular weight heparin, we don't see much of it. We don't see it at least in our adult population, we don't see much. And as he rightfully says, I don't think we look for it enough also. So you find in a course of 1 week, we've only done one platelet count, and we don't repeat our platelet count unless we see obvious bleeding. So I think it's also, we don't look for it enough.
There's also a question for you still. Yeah, Dr. let me just follow up that question again. Especially in the population of the patient itself, the pregnant, the pediatric patient. Yeah, I'm being just away from my seat. So two conditions in pregnancy, the hypertensive disorder, especially preeclampsia with severe features, and you have thrombocytopenia. And of course, in addition to pregnancy, hypertensive disorder, high risk definitely, so need for prophylaxis. So is there like a cutoff platelet count that then would need to avoid heparin related molecules? That's one question. Number two are patients who have suspected thrombophilia, especially immune related, the ITPs, where your platelets sometimes can go down as low as 50, 20, even less than 10. Yet they have the risk for VTE. What options do you have in terms of thromboprophylaxis? And worst case scenario, if they develop VTE, what options do you have based on our local setting in terms of availability of choices? Thank you.
I think the most important thing is for thrombocytopenia is to grade. Yeah, there's a grading for thrombocytopenia. And the European Hematology Association released a guideline the other day on specifically anticoagulant management in patients with thrombocytopenia, because it's been a challenge and it is not just mentioned briefly in most guidelines. So there, the thrombocytopenia is defined as platelet count less than 100, not merely lower than the lower limit of normal, as we tend to interpret. And this is WHO 2 standardization. So if you have platelet count between 100 and 75, really give full, and patients are not bleeding, give full, and there is need to anticoagulate or do prophylaxis, do full dosages of whichever anticoagulant you use. If it is 50 to 75, those are just if you marked anticoagulant or do prophylaxis for patients at high risk. Below 50, that is where the cutoff is for patients who have platelet count below 50. If the risk, if they are at very high risk of thrombosis, or they already have thrombosis, most guidelines recommend half. You don't adjust half. They are 50 to 75, you can do 25% dose adjust. The absolute platelet count less than 25. This is 25 times 10 to power 9. Stop coagulants. But you get patients like who have some massive PE, or and you have to, the platelet count is 10, 20. You can't, if you don't anticoagulate, definitely they die. Then those ones, you give platelets, transfuse platelets, and anticoagulate. So that is at least the European Hematology Association document. I mean, just dedicated to thrombocytopenia. That is their recommendation. For patients with ITP, we get a lot of them. Some of them get PE because it's an autoimmune. They could be having other, it's a syndrome. They are also predisposed to. There's no contraindication to DVT treatment or prophylaxis, but you have to grade the platelets and risk stratify the patient. If it is distal DVT, very low risk of thrombosis, platelet count is 25. In a patient with no other, high risk factor for thrombosis, no malignancy, or the cancer is controlled, then you can withhold the anticoagulation and monitor. So even for your obstetric patients with HELLP syndrome, the low platelets, if you remember the risk stratification for determining who to give prophylaxis or not, and then you score this: low risk, high risk, or very high risk. So low risk and intermediate risk, you can do your pressure stocking, other means of DVT prophylaxis. But high risk and very high risk, those ones you have to dose adjust given the platelet count, or give platelets and continue the prophylaxis or treatment. But I agree, it has been a very hazy area in most of these guidelines. I will share that European Hematology Association document on management of anticoagulation in patients with thrombocytopenia. Yeah.
I think we have two questions. One is already on the screen. The patient has swollen legs and the face after delivery. Is now 2 weeks. What should I advise the medication to help? And there's another question for the cardio team about peripheral vascular resistance. And people are saying that if you find a patient with decreased blood flow or venous flow using ultrasound, what do you do?
So you mentioned swollen face and swollen lower limb, right? After delivery. So basically it calls for clinical evaluation of the patient. Are we having swollen face as a marker of a renal function problem? Are we having a swollen face as a marker of generalized endothelial damage in hypertensive disorder? Or why are we having this swollen face? This lower limb that is swollen, again, we have to do not only the risk stratification, but do a clinical examination of that limb. And if it is a unilateral, like in this case, then indeed, based on risk stratification, you want to decide how is the risk or suspicion for DVT in this limb. And then in that case, we may need to intervene and start anticoagulation, even as we do compressive ultrasound. The compressive ultrasound rules out a DVT. We need to look at other causes because even cellulitis can cause a swollen lower limb. Okay. However, if suspicion is persistent and we still, I think, despite a negative compression ultrasound being negative, we continue anticoagulation as we follow through with a repeat CUS afterwards until we objectively rule it out. But I have a hematology team in the house, probably could add more information. Thank you very much.
Yeah, I think for that, I think you've adequately covered. The second question was about patients who have stresses. Yeah, it's a risk factor. If you look at other risk, there are those risk factors that have been established through logistic regression modeling, and they have recurred several times. So that does not mean that those are the only risk factors to look at. Like varicose veins, you will not find it in some of these scoring systems, but it is a risk factor to developing DVT. And venous stasis from, I want to give valvular dysfunction, isn't it? Yeah, it's a risk factor for DVT. So these are patients that on top of what else they have, they need to be anticoagulated. If they have venous stasis or varicose veins and they have a malignancy, they have other comorbidities, you risk stratify and decide who to give prophylaxis. But varicose veins per se or venous stasis because of incompetent valves and all that, in the background of no other comorbidity, I think it doesn't warrant primary prophylaxis with pharmacological methods. But the other means people can use pressure-graded stockings, lifestyle modifications, and all that. Like for some of our patients after DVT, they develop what we call post-DVT syndrome, which I think one of our students has finished that study. They are soon publishing the incidence of post-DVT syndrome among patients who have developed, who are treated for DVT, and it was high, about almost 33% had post-DVT syndrome with very significant impact on quality of life. And of course, these are patients, sometimes you advise them on lead elevation, pressure stocking to avoid and to manage the post-DVT syndrome. I know there are some drugs people probably, I don't use the Daflon. I think it's just expensive but almost every patient with the varicose veins or incompetent is put on Daflon, and it's very expensive and like a placebo basically.
Yes, just killed Daflon. Yeah. He can't kill Daflon so long as you have the GI surgeons and things to do with hemorrhoids. A whole spectrum of things that these things are being used for. Just curious, and probably to pick your mind on this. Two things we are probably ignoring and not talking a lot about. One is the ubiquitous aspirin, low dose, normal dose aspirin, or therapeutic aspirin for whatever purpose. Secondly, we're in a society that has gone herbal and is using a lot of additives, both in food, supplements, and things that are offered as therapy. Ginkgo, and other spices. What are your comments?
Thanks. This was also asked with a diabetic question about diabetic patients. Are they getting prophylaxis using the aspirin also, right?
Yeah, that's a very good observation and question. Starting with aspirin, these antiplatelets, aspirin, clopidogrel in management of VTE. For a long time, people have been using aspirin for patients who cannot tolerate warfarin, or very elderly patients at increased risk of bleeding, or sometimes patients who have used warfarin for so long that you're not just sure whether you want to stop, and they, so they are put on aspirin or clopidogrel. I used to think it is should be, discouraged. But then when I read ASH, the American Society of Hematology guidelines, I saw a small recommendation for specific group of patients who are intolerant to warfarin, are intolerant to DOACs, low molecular weight heparins, and most of them were elderly patients, like 90, 80-year-old. You put them on warfarin, and within a few weeks, you are told they are non-responsive and all that. So, and then DOACs also, the risk of bleeding is a bit higher. So for that small group of patients, aspirin. The other thing about aspirin and clopidogrel is arterial thrombus. Because you see, arterial versus venous, the arterial thrombus, the main thing is platelet disorder, platelet aggregation. Therefore, these antiplatelets, aspirin and clopidogrel combined, really helps. And this is exemplified in coronary syndromes where aspirin and clopidogrel are key. The other thing, aspirin, when we have myeloproliferative neoplasms, these are diseases that come with very high platelets. And you see, platelet count is very interesting. When you have platelets until 1,000, your risk of clotting is high. So patients who have high platelets, 450 up to 1,000, they have a higher risk of clotting. Now, when platelets count surpass 1,000, now you have the higher risk of bleeding because of platelet dysfunction. So for those patients who have myeloproliferative neoplasm, essential thrombocytosis, polycythemia vera, or very high, red cell counts, we use aspirin as primary prophylaxis for DVT, because they are also the patients who are likely to have a DVT, the very unusual signs like hepatic brain thrombosis, so-called Budd-Chiari syndrome, and all that. So that also aspirin world over has its very good recommendation for that. The other recommendation for aspirin is the multiple myeloma patients who have multiple myeloma and are on lenalidomide or thalidomide, because these ones also have a specifically high risk for DVT. Again, we use aspirin. So yes, aspirin is very central in prophylaxis, but not treatment. The primary or secondary prophylaxis for DVT. For herbs, sometimes we say, Prof was my teacher, and when somebody asks me questions about herbs, I usually say I want to restrict myself to what my teachers taught me. And during those days, nowadays there are topics on herbal medicine. Yeah, but some of the herbal medicine, there is no controlled trials. So sometimes we restrict ourselves to treatments with randomized controlled trials. They could work, but at least when we subject them to clinical trials, then you might find that actually some of those herbals can be alternative. But before we expose them to clinical trials, then it would be hard for me to respond. The other thing I want to say before I forget, these DOACs, I know you are asking now which one, rivaroxaban, apixaban, doxaban, they have never been tried head to head. So you can use rivaroxaban, you can use apixaban. There is no head to head
trials. Most of the things they do is they try a DOAC with heparin, DOAC with low molecular with heparin, DOAC with warfarin, but they have, I think they fear, trying them head to head, because you see, some of the recommendations might not go down well. So that head to head comparison is still lacking.
So, one question.
So good afternoon. I'm Dr. Pondo. I came a bit late. So in terms of just on follow through on the question on DOACs, that there's no head-to-head studies comparing them. But in terms of literature review, we see that in oncologic patient, maybe patient with GIT malignancy, we see some DOAC having more bleeding compared to others. Can you comment on that? Thank you.
Yeah, thank you, Moses. Moses is interested in DOACs. I think he wants to do some research in DOAC. So he's been reading a lot about them. Now, when in those trials that I've mentioned, the AVAD, the Cassini, the Koski trials, they did something called subgroup analysis to assess bleeding risk. And a certain group of patients had slightly higher risk of major bleeds. And these are the GI malignancies. Number one, unresectable colon cancer, unresectable gastric, unresectable duodenal. Those ones have a higher risk bleeding. And since reversing bleeding secondary to DOACs is a big challenge. So these ones have specific recommendation. And when there's a slide I projected about special considerations. So those are patients you have no choice but just low molecular weight heparin. So yes, there's a slightly increased major risk of bleeding such GI and bladder. So patients with bladder malignancies who are bleeding or unresectable. The story changes when you have completely resected colon, completely resected gastric, completely resected duodenal rectal, then and the patient is in remission from cancer, then you can use the DOACs.
Any last burning question? I know you've kept you standing for long, which is good. No DVT.
So someone is asking sometimes you use these terms and assume everybody understands. Somebody is asking what is DOAC? It's directly acting anticoagulant. That they inhibit the factor 10. You look at the clotting factor pathway, they directly inhibit factor 10. Drugs like the other drugs have sort of indirect effect on the factor 10. So the reference is the factor 10. So they directly inhibit factor 10. That's why we call them DOACs. We used to call them novel, but I think the term now has been changed. So it's now NOAC. People use NOAC, DOAC, NOAC.
Thank you, Doc. So let's give him a really huge hand of applause. I really know that the field of cancer and chemotherapy is very confusing. I won't lie, my first exposure was with buckets when I was in internship. And you treat a kid after 6 months, they're in remission. After 1 month, they come back with twice the size of the jaw, which they started. So cancer is, I don't know how it happens. Maybe one day we should have a CMN, what causes cancer? And if we can rely on herbal. But really, I think all the speakers, we can give them a really big hand of applause. And if they have any questions, please continue. We want to end the online session and then we'll continue with the breakout session for like 30 minutes and then you can go for lunch. So do you have anything to say for the guidelines release before we release the online people?
So the guidelines are going to be released soon. In the next few months, we will let you know, and the online team, we will also share with you. So as soon as we have them ready, approved, we will share.
Thank you so much. Thank you for attending. Please fill the feedback form after the session. We will have a last CME this month on 22nd June on, again, DVT in pregnancy, but now we'll touch some different aspects. Thank you for attending. Online team, and you can continue the physical team.